Welcome to today's webinar, CEO Compensation Meets Pay for Performance, Emerging Trends for Executive Pay, which is made possible through the generous support of Truven Health Analytics. I'm H&HN Senior Editor Susanna Hopsollerin. As hospital boards and leadership focus on reform, rising costs, quality improvement, and increasing transparency, Truven Health Center for Healthcare Analytics performed research to assess whether a score for overall balanced organization performance could be associated with CEO compensation. The preliminary research results were published in the article The Right Rewards for CEOs in the October edition of Trustee Magazine. Today we're going to find out why this is a hot topic in healthcare today, what the governing rules are from the IRS, what current board practices are, and what data is appropriate for comparison. And we'll hear from two healthcare executives on the pros and cons of greater transparency of compensation information and the feasibility of pay for performance. I'd like to welcome our panelists, Jean Chenoweth, Senior Vice President, Truven Health Analytics. Jean has been involved in the development of healthcare information for the improvement of hospital management and clinical performance for more than 30 years. She's led research on developing a national balanced scorecard for hospitals around best practices in leadership, clinical quality, and operations. She also directs the Truven Health 100 Top Hospitals Benchmarks for Success and the 100 Top Hospitals Performance Improvement Leadership Programs, which annually recognize hospitals and management teams for long-term organization-wide performance. We also have with us Kevin Talbot, Executive Vice President of Integrated Healthcare Strategies. As the practice leader of total compensation and rewards practice, Kevin leads one of the country's largest and most respected consulting groups dedicated exclusively to compensation, benefits, and governance in the healthcare industry. He manages a national client base of over 300 healthcare organizations, ranging from some of the country's largest health systems to independent community hospitals. As an expert on governance of executive compensation, he works closely with boards to help them remain compliant with regulatory requirements and establish best practices for governing their executive compensation programs. We also have with us Paul Pawlak, President and CEO of Silver Cross Hospital. Paul has been with Silver Cross Hospital since 1990. As the hospital's longest-serving CEO, he has led Silver Cross to be recognized nationally for outstanding customer service, effective cost management, and superior quality, winning the prestigious 100 Top Hospitals National Award for 7 consecutive years. Silver Cross has also been recognized as one of America's friendliest hospitals by the American Alliance of Healthcare Providers for several years. We also have with us Richard Suhu, Chief Financial Officer at Sutter Health. Richard has worked in various finance roles for Sutter Health over the past 25 years and is currently the Chief Financial Officer. Sutter Health is known for providing consistent level of exceptional personalized care to patients. The Lewin Group recently ranked Sutter Health as California's top health system in healthcare quality. Before we begin, I'd like to draw your attention to the red Q&A button at the bottom of the console. That's where you click to ask a question. Also, you can download the slides as well as the article from Trustee Magazine on the right rewards for CEOs, you click on the green resource list button to access those slides in the article. I'd like to turn the panel over to Jean now.
Thank you very much, and thank you all of you for joining us. CEO compensation has been a hot topic since Time magazine writer Stephen Brill published his treatise on the state of the hospital industry, hospital costs, and CEO compensation. And that led to an onslaught and ongoing series of publications on CEO compensation, thereby putting pressure on board committees. Another area that has added to the discussion about CEO comp has been the Institute of Medicine's triple aim. This has led to research by academics on CEO compensation. And the findings of Karen Joint et al. At Harvard received heavy press coverage. She found that using the IRS Form 990 to identify CEO compensation and then linking some public data to that led her to conclude that CEO compensation in hospitals was significantly related to size and teaching status, the use of high technology, which is equivalent to teaching status and size, as well as good HCAP scores or customer satisfaction with their perception of care. They did not find that CEO compensation was related to financial performance, clinical outcomes or process of care, and community benefit. And they made a policy statement or question about whether hospitals that receive significant tax support should the board's comp committees relate CEO compensation directly to quality of care and community benefit. Another study, again from Harvard, was done by Jha and Epstein, and they did a survey of over half of the not-for-profit board chairs. They found that in terms of priorities for board oversight, over half of the board chairs thought that quality should be one of those top two priorities. But they found that only 44% of the board chairs did not consider quality to be one of the top two priorities for board compensation. As a consequence, Integrated Strategies and Truven decided to perform a study that better reflected what we believe is the board's true responsibility, and similarly what the CEO is truly responsible for, which is the overall health of the organization. As a consequence, Integrated Health Strategies provided CEO compensation survey data from more than 487 hospitals and 89 health systems, and we at Truven matched the hospital's composite scores on the 100 top hospitals balanced scorecard. The detail of this study is in the Trustee magazine, so I won't belabor the point. What is important is that we use the 100 top scorecard because it is credible, defensible, and has been studied by academics independent of our organization. So that reflected true performance across the hospital's organizational outcomes of quality, expense, the customer's perception of care, safety, and efficiency. Our study found that there was a very high correlation between overall balanced performance across the whole organization and CEO compensation. In addition, not only was there a strong correlation across the whole organization's performance, but for every increment in increased performance, we found a similar increase in direct compensation, which suggests that the boards really are focused on the overall health of the organization itself. Our conclusion is that boards are proactively looking at incentive pay as a way to encourage increased performance and ongoing improvement. And that is especially important now under the Accountable Care Act, where CEOs are engaged in cost-cutting and maintaining high quality and improving it. That is the study, and now I'd like to turn this over to Kevin Talbot, my colleague, to talk about what the best practices are of board compensation committees. Kevin?
Thank you, Jean. So I want to walk you through some best practices in governing executive compensation and talk a little bit about the regulatory environment, which really frames the process for setting executive compensation, most of which across the industry involves some level of pay for performance through the use of performance-based incentives. So that discussion starts with the authority typically given to a dedicated compensation committee of the board, and best practice is to have a separate independent committee charged with reviewing not just CEO compensation, but all key executives, senior executives across the organization. That committee has a written charter which clearly outlines the process for making decisions, who should be reviewed, how frequently, as well as the setting of any performance-based goals that are used to determine executive pay. Now, there's a process that the IRS outlines, and I'll walk through that here in a moment, but we do advise that those charters and those committees, as part of their process, specifically state their intent to establish what's called a rebuttable presumption of reasonableness. And we'll walk through that process here in a moment. This whole regulatory process starts with the Taxpayer Bill of Rights 2 and IRS Section 4958, commonly known as the Intermediate Sanctions Regulations. And the high level of this is that board members approving executive compensation need to make sure that pay is reasonable, that it doesn't constitute an excess benefit transaction. And we've listed here on this slide some of the things that are considered excess benefit transactions. The one that most attention is paid to is unreasonable compensation. If unreasonable compensation is paid, it opens both the trustees and the individuals receiving unreasonable compensation to potential penalties from the IRS. So there is a process that the IRS outlines, and we advise all organizations to follow. That's the rebuttable presumption of reasonableness I mentioned before. It's really the easiest and most effective way to help protect from these potential intermediate sanctions. It's also good governance. If you follow this process, you're most likely to ensure that your pay for executives is reasonable. And if established, this presumption shifts the burden of proof to the IRS to demonstrate that any pay is unreasonable. So it's a great way to manage risk and protect the organization and the individuals. Establishing this rebuttable presumption or safe harbor of sorts is actually quite easy. It involves 3 key steps. The first one is that total compensation, and this is all elements of compensation, not just salary, but incentives as well as benefits and perquisites, must be reviewed and approved by a completely independent board or a designated committee of the board for all disqualified individuals. For the sake of argument, we'll call it disqualified individuals your senior executives, people with significant influence over the affairs of the organization. The second part of this process is that the decisions of that committee have to be based on the appropriate comparability data. So what this means is that in setting pay, you're looking at other organizations like you and other positions like the positions you're reviewing. And again, this comparability data has to be on total compensation, including performance-based pay. And then the final step in the process is simply documentation done through your minutes that need to be complete and thorough and timely. So 1, 2, 3, a fairly straightforward process. So thank you, and I'm going to pass the panel discussion back to Susanna.
Thank you, Kevin. Right now we're going to hear from the 2 healthcare executives, Paul Pawlak, President and Chief Executive Officer at Silver Cross Hospital, and Richard Suhu, Chief Financial Officer at Sutter Health. Both Silver Cross and Sutter Medical Center have achieved exceptionally high performance in comparison to peers across the country. And both Paul and Richard are comfortable and advocates for use of measurement for assessing performance. So we're going to explore with them their thoughts about the new level of scrutiny that is being undertaken regarding executive pay in healthcare. Paul, could you tell us a little bit about the approach that your organization is using for pay for performance with you and other top executives?
Sure. Silver Cross Board of Trustees, approximately 15 plus years ago, established our pay performance system, and it's used for all our higher level executives, and those with the highest percent at risk is the CEO. Our executives all have corporate goals as well as individual goals, and at the end of our fiscal year, we determine how well we do. The goals are also approved by our board, and all this is done almost just before our fiscal year starts. And our focus really is on quality, financial, and strategic initiatives that we have planned for the next year. We do not have a long-term incentive program, just an annual one.
Richard, could you please describe for us how your program is implemented and whether or not it's by an annual incentive, or do you also use long-term incentives?
Yes, thank you for the question. And much like as Paul had described, our incentive plan is very similar. We do have a compensation committee that reports to the board, and our pay for performance is overseen by the compensation committee that reports to the board for authorization and approval of incentives. And we do have both. We have a annual incentive, and we also have a long-term incentive plan. We call that our LTIP, a long-term incentive plan. And the structure behind that is really, as we set goals for the organization, we know that some of the goals are multi-year, and so we do it over a 3-year cycle, the long-term incentive plan, so that we can make sure that we're measuring and driving towards the long-term goals of the organization. On our annual incentive plan, as Paul had mentioned, we have similar, but we also include several quality metrics as well. And we also add in our patient experience. We call it our service excellence, which is our patient satisfaction scores. We also have a community involvement metric where we look at our community benefits at both cash and in-kind investments that we make in the communities that we serve. We also add in a strategic objective along with our affordability and finance goals here at Sutter Health.
Paul, how far down in the organization does pay for performance extend? Is it just on that executive level, or does it go down to middle management and possibly even the frontline staff?
Our incentive program, of course, is for our executives, but then it goes to management and even goes down to our frontline employees. And we also have our medical staff attached to some of our corporate quality goals. So everyone here at Silver Cross is impacted by it. And then we're transparent, and we get back to people on a daily, monthly, quarterly, and yearly basis of how we're doing. So everyone knows where they're at and where we need to go.
Richard, in your organization, are you aligning pay for performance across physicians and executive leadership?
We do have alignment, but here at Sutter Health, being that we're in California, we do not employ our physicians, so our alignment is a little bit different.
And are you also going beyond the executive level with your pay for performance down to middle management and frontline staff?
Yes, we also take it to the middle management level. We do not take it to the frontline staff level. The one difference in our incentive plan we call it our management incentive plan for our middle managers, which is the difference is a couple of the goals. On our middle management goals and incentives, we do not have a strategic goal, but all the other goals do exist. We try to mirror them so that, again, as Paul said, it's transparent and very visible.
Paul, how do you set the executive pay for performance goals in your organization?
Well, every few years we develop a strategic plan, and we certainly look at that. And so that's important when we develop our strategic initiatives. We look at our quality scores, and when I say quality, at Silver Cross, that means clinical results as well as customer satisfaction. And so we look at all the prevalent quality scores that are necessary to be a better and fine hospital. And then for customer service, we look at Press Ganey and HCAHPS. And then we also look at our financials. And, of course, our financials are tied to our strategic plan. So once we develop that, management presents our proposed goals to our Governance Management Effectiveness Committee, which is our compensation committee of the board. They look at it, they make adjustments, and then they refer to the full board in which they approve.
Richard, what's the process for setting executive pay for performance goals like at Sutter Health?
It very much mirrors what Paul just referenced. We do the same thing in process. We take our incentive, our goals from previous years, and we look at, we have basically maintained them over the years, the 6 categories that we have on our incentive plans. And that does go to comp committee. They review, they also look at previous year's performance and establish what the metrics should be and at what levels. We actually have from the comp committee sets 2 different levels. One is a threshold, which is at 50% of the goal, and then the other one is full performance if you actually hit 100% or exceed that. So they actually have 2 weighting factors in the goal setting.
And Richard, has this changed over the past 5 years, the nuances of how they are setting the goals and measuring them?
Fundamentally, they've remained the same over 5 years. What we're trying to do is mirror them with reform and how we integrate that so that it's an aligned incentive. That's probably where some of the changes are, looking at our affordability agenda. making sure that we're staying consistent with that, as well as access. We do have a strategic goal, which is on growth and trying to create access.
Paul, have things changed in your organization over the past 5 years?
They really changed dramatically here at Silver Cross. We were fortunate in the last 3 years to build a new hospital. And as we all know, there's a fair amount of financial risk associated with that. And at the same time, we were able to develop 5 academic affiliations with some of the hospitals in Chicago. And our quality and our customer satisfaction scores have remained high. We had a lot in the air, and we went through an IT conversion at the same time. So by having these realistical, stretch, attainable goals, our management team, our mid-management team, and our employees were able to put this together. And at the end of the day, our board was extremely pleased with the progress we made in the last 5 years.
Great. Richard, could you comment on how effective the use of metrics for determining pay has been in supporting the organization's improvement strategies?
I think it's been extremely effective, making a real positive difference in carrying out the strategic initiatives of the organization. We also went through a support function transformation, and we're still at the kind of on the tail end of that. And that was one of the things that we had put into one of the strategic objectives for the past 2 years, to make sure that the back office support functions and going to more of a systemness, if you will, we were able to achieve that, and making sure that all of our aligned affiliates were aligned with that concept and supported that. And so we were very successful in that. So that has made a huge difference in the alignment. We have 2 divisions within Sutter Health. We have 27 affiliates within those 2 divisions. So driving the systemness and the system perspective is really important. And we cover a geography within the Northern California area. So having the incentives and the scorecard that we look at, the dashboard, it has really proven that it's a real positive influence to our effectiveness in making sure that the goals are carried out each year.
Paul, in your organization, when you've looked at specific improvements, how have those metrics helped in terms of meeting those goals?
Well, one of the most important tools we use is Truven, and we look at the scores in relationship to other hospitals. And if we're at the 75 percentile or higher, our goal is always to be at 90. We just put that on maintain mode. And so if we're at 40, 50, or 60, or elsewhere with any of our metrics, then we develop a plan of how we can take that 50 to 75 or higher. And then based on that, we assign responsibilities for various executives, mid-management, and even the medical staff to accomplish that. And for the most part, it's worked extremely well. At Silver Cross, we have a phrase, if we can measure it, we can move it. And right now, we're measuring about 200 plus metrics. Sometimes it becomes a little overwhelming, but usually we narrow it down to the top 8, 9, or 10.
And Paul, how is that working with aligning pay for performance across the physicians and executive leadership?
Well, we have our corporate quality goals based on a lot of different measures we want to improve. But I will tell you, we just align with Advocate Healthcare, and they have a Advocate Physician Partners, which is the largest ACO in the country. They call it APP. And a lot of our measures now, quality, are being aligned with APP. I want to emphasize, though, we're not part of Advocate. We did not merge with them, and we're the only non-Advocate hospital on that ACO board. And it's had a huge impact, improving our scores. And then once again, of course, we're using Truven and others.
Richard, what kind of communication tools are used with your board and with participants to measure and demonstrate how well the organization is performing?
Yeah, we have our executive dashboard, and starting with our management, our executives. Each of us have an executive dashboard that is out on a portal we have, and we can go in at any time and look at the dashboard and see how we are performing personally, how our areas are performing as well. There are definitions of the metric as well as the data source, so we know where the data is coming from, and it also has the updates of the frequency in there as well. So we constantly continuously know how we're performing on certain metrics and measures. We, too, use the Truven Analytics a great deal here in our organization, measuring how we do. We also tend to use the Truven Analytics to benchmark ourselves against each other because the data is there, as well as we have a diverse number of hospitals in different sizes and geographies, so we will do peer groupings of those organizations as well. From the board level, it is presented each board meeting on how the dashboard is performing to the targets there, and so it is constantly reviewed. But our management team definitely knows, and we look at it at each one of our executive meetings as well.
And Paul, what kind of communication tools are you using with your board?
We use basically about the same measures to share that information with the board, medical staff, our employees, mid-management. Richard referred to it as the dashboard. We call it the balanced scorecard. And so that's available really 24/7, and we share it with the various committees of the board, quality, and, of course, with the full board every time we meet.
Richard, do you believe that the executive goals and related performance should be transparent?
Yeah, I definitely do. We as an organization really have pushed the initiative of transparency. So we will not stop at the goals of the organization, not to make those transparent. I think it's also setting strategy for the organization, and strategy goes throughout all levels of the organization, and those goals have to be known so that individuals know what we're trying to achieve and where it's going to take us. At the affiliate levels, there are sessions that are done sharing the goals at the beginning of the year and throughout the year so that we know how we're performing. Sometimes we get a little bit behind, and we have to ramp that up to make sure that we get back on task for those goals. So I believe that transparency is imperative, in that all levels of organizations must know what the strategic initiatives are.
Paul, what about at Silver Cross? What role is transparency playing in terms of those executive goals and performance?
Well, I agree 100% what Richard just described, but, I take it maybe a little different way. If we're all operating on the same page, and for the most part we all have relatively the same goals and aspirations, to some degree that also formulates the culture of the organization. And if you can establish a culture that's high-performing year after year after year, then the expectations, of course, get higher. And, it's kind of contagious. It's kind of contagious with your employees. It's contagious with the board. Of course, they expect more out of management. And it's also contagious with the medical staff. So it's a good feeling to be involved in that. And unfortunately, we dropped out of the top 100 status the last 2 years because we were carrying too much interest and depreciation for the new hospital. But we're going to be back in there for 16.
Thank you, Paul. I want to thank Jean and Kevin and Paul and Richard. And I'd also like to thank our sponsor, Truven Health Analytics, and invite questions from our audience, who we thank for joining us. I'd like to remind our audience that to ask a question, please click on the red Q&A button at the bottom of the console. Also, we do have resources, and look at the green resource list button, and there you have the slides as well as the article from Trustee Magazine. I'd like to start with Paul. Paul, why haven't you developed long-term incentives?
You know, our board looked at this several years ago, and at least from their perspective and mine, we've had a great deal of success with our annual incentive compensation program, and they decided they'd like to stay with that, and that's where we're at right now.
Richard, could you comment on what's the advantage of having long-term incentives from your board's perspective?
Yes, from the Sutter perspective, there are initiatives that we have, and as we know that the evolution of healthcare and reform, some of these initiatives will span more than just one current operating year. So we adopt the process of long-term to carry it over a 3-year period to make sure that we stay focused on multiple years of carrying out and implementing the initiatives.
And Kevin, what do you see as trends nationally? Are organizations using the long-term incentives more frequently now?
Well, across the country, if you look at all hospitals and systems out there, long-term incentives still remain fairly uncommon. Maybe 20% to 25% of all organizations have them. Now, they're much more common at larger, particularly multi-hospital systems, and much less common at smaller organizations where you'll see, fewer than 10% have them in place. We have seen since the beginning of the Healthcare Reform Act, where there's a lot of long-term change being impacting the industry. We've seen an increased discussion and a slight uptick in the prevalence of long-term incentives, but they still are used fairly infrequently. One of the reasons why we hear organizations don't want to use them is that it can be difficult to set long-term incentives 3 years into the future in a very uncertain environment of healthcare reform. So what a lot of organizations do, they'll have a long-term strategic plan and goals within that long-term plan, but they'll just use incremental goals on an annual basis in their annual incentives to move towards and achieve those goals.
Richard, when you're setting the incentive goal targets, is it okay to focus just on improving your performance over how you did the prior year, or should you be benchmarking your progress against your peers? And at Sutter, are you benchmarking various regions against each other and then also looking at some external organizations?
Yes, much like the Truven 100 top hospital data analytics, we measure current year performance, but also multiple years. We measure our rate of improvement, which is very important to us. We have to set a threshold, a benchmark, and then we move forward from there looking at the improvement to see if we achieve that goal. But we also measure both within our own organization, and we look at the types of different hospitals as we have. We could have a community hospital. We could have a tertiary medical center. We'd even have a rural hospital. So we do benchmark within those. We also are in California, so we look at our market basket area, and we benchmark within our competition of California hospitals as well.
And Paul, what about at Silver Cross? Are you looking at performance over the prior year, or are you also benchmarking against peers?
Well, we do a little of both. If we're looking over prior years, and let's assume that we're at the 70th percentile, and we want to be at the 90th percentile, we'll keep that in there. Once we receive the 90th percentile, we'll move on to something else and bring in a new goal and objective. But without a doubt, we're always comparing ourselves against the Chicago marketplace, the state marketplace, and probably more importantly, Truven Top 100. Our goal is to be always north of the top 75.
Jean, what are some of the trends that you're finding when organizations are setting these incentive goal targets and how they're benchmarking against their peers?
Well, the most important thing that I see is the power of the rate of improvement. Not all hospitals are on smooth seas each year. And so sometimes performance will fall. And therefore, that rate of improvement and having national benchmarks is really, really important for boards to understand how much they and the executives have impacted the organization. The other thing is hospitals are the biggest employers in their community very often. And it is very, very important, as the research showed, that the hospital remain in balance. If you are too heavily focused on financial performance, quality can suffer. If you're too, but of course the hospital will be in good shape, but for investing. But if you're too heavily on the quality area, and pay no attention to finances, it can put the condition of the hospital in danger. So being able to look across multiple metrics and see, as Paul and Richard have both said, they're looking at some local standards and some state standards and some national standards to make sure they stay in balance.
Paul, what are the standard items that are included in executive pay at Silver Cross?
We always have a quality measure, and the quality measure can consist of 3 or 4 items. We always have a financial goal, and then the other 2 revolve around strategic initiatives. For example, we just built a new hospital. We developed affiliations. And our strategic initiatives really are coming out of our 3-year strategic plan.
And Richard, what about at Sutter? What are the standard items included in executive pay, and how is that changing as measurement and goals are added or deleted in the evaluation process?
Similar to Silver Cross and what Paul had mentioned, we also have quality, our core measures. We track that very closely. We have a finance affordability metric as well as a community metric. And patient satisfaction is very large to us to make sure that we are servicing our patients and we're meeting their criteria that they have set. We do use Prescanian age caps now.
Kevin, how does that compare to the national trends in terms of standard items included in executive pay?
That's very consistent with what is seen at most organizations. In recent years, there have been the introduction of new types of metrics. As you can imagine, organizations are focusing resources and energy on population health management. Sometimes that results in the introduction of new types of metrics focused on those areas within their organization. Engagement scores for their employees and their physicians. The measurement and improvement of that engagement is becoming fairly common as organizations recognize that a highly engaged workforce and highly engaged physicians going to have significant and direct impact on outcomes and patient experience. In terms of some other shifts in the elements, the typical elements of an executive pay program, you have your base salary, and most organizations by far have some sort of incentive type pay, and then there's your benefits making up maybe 25 to 30% of the total package. We have seen boards having a lot of discussion around increasing the amount of pay tied to performance and holding more conservative levels on the guaranteed or base salary portion of the total compensation package.
Speaking of boards, Richard, the board is always struggling with whether performance is really good enough to justify bonus payouts. How do you answer that question of when is the performance really good enough to pay an award? Paul, can you answer that question?
Yeah. One of the things that we do at Silver Cross, and we do this on an annual basis, we, of course, determine what our goals are going to be, once again revolving around quality, financial, and strategic initiatives. And invariably, there are many instances where you're looking at cost savings, you're looking at additional revenue, you're looking at various incentives the hospital can engage, whether that's with an ACO or Blue Cross, whatever. And the quality measures, as we all know, of HCAHPS now involve various monies. At the end of the day, our incentive system is more than paid off from all those things that we accomplish through our goal system.
Kevin, can you talk about what you're seeing in terms of trends when boards feel that there really is good enough performance to pay an award?
Yeah, absolutely. There's always, a natural, healthy, I'll say tension, maybe that's too strong of a word, but dialogue between the board and management on what exactly that definition is of what's good enough. 10 years ago, we would often see organizations looking at how they did last year and saying, well, we did better or worse than last year, and that's the story. And nowadays, what we see more frequently, is, as was mentioned earlier, is not just looking at how you've done internally, but how you're comparing to the industry or your particular competitors or peers. And I find, using something like the Top 100 Balanced Scorecard is a huge, huge help in building consensus across the board and management when having those discussions. You can look at how you're performing against not only yourself, but then look at, as Jean mentioned, your rate of improvement and your actual achievement. And I think all those things together are critical to answering that question.
Okay, thank you. We found out Richard lost his connection, so hopefully he'll rejoin us soon. Paul, has your board or have you felt the need to respond to the media coverage of CEO compensation?
Our salaries have been out in the public, and when that does happen, our chairman of the board is our representative that speaks on behalf of the hospital. And this has happened to Silver Cross and its management team. And in advance, we try to make sure that our employees as well as our doctors understand the implications. And so far, it's been a positive result. People understand what's at stake for the hospital, the risk involved in managing the hospital, and then the goals that we want to aspire. People kind of understand what that compensation is derived from.
Jean, what are you seeing in terms of trends on boards' responses to media coverage of CEO compensation?
Well, it varies by market. I mean, you've seen everything from, the story in Time Magazine, The Bitter Pill, where there were, there was coverage of very, very high pay for certain CEOs in the country. Most CEOs are of hospitals that exist in small and medium communities. And in those communities, often the hospital is the largest employer and the most complex organization in operating in that community. And as a consequence, there's been some eyebrows raised in relationship to what some of those CEOs are paid. But when one considers the size of those organizations against for-profit companies that are of similar size and even less complex, the salaries are quite reasonable. So it poses an issue in some of the smaller and medium-sized communities to educate the community about the importance of the hospital as an employer and how it gives back to that community. And I have seen some of the hospitals doing that.
Kevin, how has the release of CEO compensation information to the public impacted organizations, and what kind of an impact does this have on their perception in the community, and what advice can you give to organizations that are dealing with this?
Well, this is a real issue, and first of all, we typically tell clients that if you haven't experienced this yet, you will at some point. The information, if you are a 501c3 and file a Form 990, is going to be out there, and sooner or later, there's a good chance a reporter or somebody in the public is going to pull that up and ask questions. And so, the best thing to do, as Paul talked about, is have a plan on how to deal with that. That plan has to be grounded in your compensation philosophy, which every organization, every board should have, and grounded in your governance process. And so what this has done in the industry is that boards have become much more attuned to first of all, what is going to be out there in the public, looking at that 990, understanding the numbers, because they're not always clear and are open to interpretation. So being prepared to answer questions about the number that is out there and what goes into it, as well as doing a really good job with your governance. And so we've seen boards sort of, and through their comp committees, really tighten up their governance process, because at the end of the day, the trustees are often the ones on the hook for answering some very hard questions. So we've seen the governance process strengthened. We've seen much more transparency, because you don't want to have a board member in a position of getting asked a question and being surprised. So you want to have transparency and have a plan in place for dealing with those types of questions.
Paul, would you like to share some of your experience at Silver Cross?
In relation to what?
In relation to the release of CEO compensation information to the public, okay, and how the community has viewed it.
To be honest with you, I thought there would be more of a reaction. There wasn't much of a reaction amongst our medical staff, employees, and a few people willing to talk to me about it. It seemed like a non-event. I've been here 25 years. The hospital's done well, and there's a certain expectation that when you come to Silver Cross, you are hopefully going to get the best possible treatment. And so with that kind of framework and culture and of Silver Cross, I think it was understandable. The one thing that maybe we should keep in mind is, a CEO's tenure is only 5 years in hospitals. And in that 5 years, you have to get a lot to accomplish if you want to see years 6, 7, 8. And the board has high focuses and demands of CEOs, and we must perform or else we're not going to be the CEO.
Thank you, Paul. This concludes our question and answer period. I'd like to thank our audience for their questions. I'd like to thank our panelists, Jean Chenoweth with Truven Health Analytics, Kevin Talbot with Integrated Healthcare Strategies, Paul Pawlak from Silver Cross Hospital, and Richard Suhu from Sutter Health. And I'd like to thank our sponsor, Truven Health Analytics, that made this webinar possible. On behalf of Health Forum, thanks for listening in.